So we're very lucky to have Professor Hunt with us today. Professor Hunt is a professor of thrombosis and hemostasis at King's College in London, as also a consultant in thrombosis and hemostasis at Guy's and St. Thomas's. She's a world-renowned figure in venous thromboembolism, its prevention, its management, antiphospholipid syndrome. She founded the obstetric hematology group as part of the British Society of Hematology, which is crucial in managing obs heme patients nationally and internationally, and also founded Thrombosis UK. So I think it's quite okay to say that Professor Hunt is the Empress of thrombosis. She's going to talk to us about VTE prevention and management in pregnancy and after delivery.
Well, thank you very much, Etienne, and thanks to the President for inviting me here. We have quite a lot of work to do in this area, and I'm going to set the scene of where we are with VTE in pregnancy. We have a symposium later at lunchtime, and if we have some overflow into that, well, that will probably be rather good. So I'm going to just sort of work out where we are now with VTE prevention and management. I don't take any money from Big Pharma, but I am part of the NHS England group that's going to try and address some of the many problems I'm going to present to you. So the aim is to understand the current issues around thromboprophylaxis and VTE management in pregnancy in the puerperium, and I'm going to make an emphasis on the first trimester, which often falls out of formal obstetric care. So, what a problem we have. We now have, despite all that low molecular weight heparin that you prescribe, the fact that venous thromboembolism is the #1 cause of death in our women in the United Kingdom during pregnancy in the puerperium. 45 deaths over 3 years, giving us a maternal mortality rate of 2.1 per 100,000. It's grim. When we look at the rest of the world, our problems are the same as the United States, who have similar maternal mortality figures. You have to remember, care in the United States is not maybe at such a high level as we offer. And when we look back over the last 10 years, this is from a paper that I did with a group of international experts looking at mortality in the States due to pulmonary embolism. It's actually dropped over the last 10 years significantly, but it hasn't changed at all in pregnancy, and it's particularly prevalent in the no socioeconomic groups, Hispanics, and some of the blacks. Where do we sit in Europe? Well, we're an outlier. So this is looking at maternal mortality at all the countries that have enhanced surveillance systems. I want you to draw your eye to venous thromboembolism. Look, this is the scale here, the number of deaths per 100,000. If we go along the row for venous thromboembolism, look who's got the highest, the United Kingdom. And when we look at the next highest, which is the Netherlands, their maternal mortality is less than half ours due to VTE at 0.8 per 100,000. So we really do have a country problem. That's not to say everything's okay everywhere else. When we look at the succinct messages that came out of Embrace, on the left, you can see there were concerns about the National VTE Risk Assessment Tool, which you all know, but which has never been validated. So there is a call. Can we make a new tool that's clear, easy to use and accurate? Can we take into account factors that arise during pregnancy and the postpartum? And can it be based on research evidence? So the last ARCOG guidance on VTE are old, well, more than 8 years old. And my research fellow has been looking at some of the risk factors that have emerged since then. Before we get there, I just want you to draw your eye to the risk factors for maternal death and note this. So BMI, only 17% of the women had a normal BMI, which means that over 80% had obesity. And we are talking about quite large numbers. And that really fits in with our population. So in 2022, those are our last figures, 29% of adults are living with obesity and 64% were either overweight or obese. Obesity increases with age, and when we look at adults over 60, they really have rates of about 30%. Obesity is a particularly British problem when you compare us to Europe. It's a similar rate to the United States. This is a cartoon out of the Observer when Sally Davis was the medical director for NHS England, and here she is saying you must eat fruit, but the message has not got through. The biggest paper looking at the effects of obesity in pregnancies is California paper. They looked at 2.5 million women who'd gone through their services and collated the risk of VTE with BMI and stage of pregnancy. So we have got different levels of obesity. This is their risk of problems during delivery, very small. However, when we look antepartum, you can see the risk increases almost exponentially. Postpartum, again, the risk increases with a slightly exponential increase. So obesity is a big factor in, I would say, in what we're seeing. At a global level, up top, up here, we've got obesity rates in the USA. They lead the world. Here we are. Here's the United Kingdom, really coming second to them. And this is showing the prevalence of obesity in women who are fertile. The darker the area, the higher the rates. And you'll see, here we are, United Kingdom, similar rates to USA, Russia, surprising that, Australia, and way down south in South America. I don't want to dwell too long on obesity, but just to remind you, it is a state where the adipocytes change when there is obesity, and they secrete a different set of cytokines in the obese adipocyte. So normally, if you're lean, your adipocytes are excreting anti-inflammatory cytokines. If you have adiposity, you have a change in signal, and you're putting out there interleukin-6, TNF-alpha, and you also put out PI1, which will turn down fibrinolysis. So IL-6 is the stimulator of the acute phase response, and will push up your fibrinogen and your factor VIII and make you more prothrombotic. A few years ago, with Ellie Morgan and a team, we looked at different sized women in the third trimester, looking to see if this increased risk of VTE with increasing size was related to hemostatic changes. Here we got leptins, And then we've got a marker of coagulation turnover and fibrinolysis. Just to summate that data, there is no difference in the level of hemostatic activation according to BMI in pregnancy. So there's some other factor which is being affected by the obesity, and we think it might well be flow. If you have large veins, your flow rate drops at a much greater rate. And we do have this issue of May-Thurner-like syndrome in pregnancy, and we need to do some research here. So coming back to ARCOG and looking at the risk factors and the studies on them since ARCOG was written up, we have got these risk factors coming through. So there's been a paper looking at physical disability, and if you're needing a mobility aid such as a wheelchair or walking stick, your odds ratio of having VTE in pregnancy is 3. Exciting and different one here is gestational diabetes. So if you're diabetic, your risk of VTE in pregnancy isn't particularly increased. But if you develop gestational diabetes, it does push your risk up. So perhaps it needs to be on a new VTE risk assessment tool. And of course, sickle cell disease, many more papers, as one came out last week, all showing really high risk rates of VTE in pregnancy. And then looking at the already established factors, well, IVF, we know we've got an increased risk of VTE in the first trimester, confirmed by these other studies, and also a study looking at lupus. But I did say I was going to talk about the first trimester and concentrate on this. And this is looking at the maternal deaths in the Embrace report, first trimester, second trimester, third trimester, and then we've got postpartum. As expected, we've got increased death rates postpartum. Even if we give thromboprophylaxis, we are reducing the rate of VTE. We are not totally inhibiting it. But what is surprising is that in the first trimester, we have got this really high rate. It accounts for 1/4 of all the deaths in the Embrace report. And yet when we look at the background rate of VTE, according to some Scandinavian work, the risk of VTE rises during pregnancy and is maximal postpartum. So something's going very wrong in the first trimester, that we are not dealing with the risk and women are dying. And they give in the Embrace report some little vignettes which perhaps explain what's happening. So we have got a vignette here of a woman who has hyperemesis gravidarum, doesn't get thromboprophylaxis and dies of VTE. Another one with hyperemesis who got IV fluids but never managed to get any thromboprophylaxis because a risk assessment said she was low risk. She too died. And in fact, hyperemesis in the first trimester accounted for about 30% of the deaths. We have some work to do here to increase recognition of hyperemesis as a risk factor, not just among ourselves, but with the patients. Here we have somebody who has had a miscarriage. Her VTE score was elevated prior to the miscarriage. She never got thromboprophylaxis after the miscarriage and eventually had a P and died. And then this is a tragedy which we have got to deal with. This one. So this is an older woman. She knows she's got a history of VTE. She knows she needs low molecular weight heparin early in pregnancy. She sees the GP in the first trimester, the GP won't prescribe, he can't contact anybody in the obstetric unit, and she dies in the first trimester of a VTE. Now, that just shouldn't be happening in 2025. And then lastly, this is a woman who presents in the first trimester with palpitations, shortness of breath, chest pain, and tachycardia. She didn't have a chest x-ray or any other imaging because she was pregnant. I mean, that's just not on, is it? We have to get women who are pregnant to be investigated properly. It's just ridiculous that they can't get the tests, and then therefore they will be labelled as having a PE, and we never really know the truth. So concentrating on the first trimester, quite often these women are falling out of formal obstetric care. I don't know about your unit, but in mine we're quite often booking at 10 weeks. We've got to be creative here. Can we think of having a VTE risk assessment tool unique for the first trimester, or just with the factors in the first trimester? Could we perhaps do a self-assessment form for women so that when they self-refer for obstetric care, they actually have to fill in a risk assessment tool that is designed for them so we can log when they've got risk? The other thing is, we don't think they know that they're at risk. So Thrombosis UK have just done a Mori poll. The results came through this morning. And one of the questions that we were asking was, do you know about the risks of VTE in pregnancy? We know the general population, really quite a good knowledge of VTE, about 70% no symptoms and signs. That's astonishing compared with the rest of the world. But when you ask them the question, is there a risk of pregnancy, particularly in the first trimester, less than 5% knew that there was a risk. In fact, it was less than 3%. Hopefully we'll do some form of press release next week in National Thrombosis Week around that. So how can they access risk assessment? I think we are heading towards a self-assessment tool. We can talk to NHS Digital about that. How can we access low molecular weight heparin early in pregnancy? We have to get the GPs involved. And the other issue is they haven't got a card yet to say, oh, well, you're pregnant, you don't have to pay prescription charges. So we have to think about how we manage that for people who have low income. The other area is abortion care. So when we look at abortions in the United Kingdom, we have a live birth rate of about 600,000, and we're doing 250,000 abortions every year, which is a stunning number. It's the same in France, it's the same in Germany. Where are they coming from? Well, it used to be high rates in the under 18s. There was a lot of public health work allowing teenagers to access contraception much more easily. But where we have a rising rate is women who are over the age of 35. So if we look at the data out there, looking at risk of VTE at the time of abortion, we just have one paper. Luckily, it's really good. So this looked at 200,000 women in Canada who had an abortion, either medical or surgical, and compared their VTE rates with women who were not pregnant, and they have showed essentially that the risk of VTE after termination in the first trimester is about twice that of the background risk. But of course, when you look at term, your risk is 8 to 10 times the background risk. So we have got risk in the first trimester, but it's not as high as later on. And we need to hold in our head that fact that we've got risk, but it's much smaller than term. This might affect how we manage them. So when we look at abortion in the UK, we've got 3 very large providers, private providers, BUPAS, MSI and NUPAS. They have a very different pathway, of course, from obstetric care. No one has ever designed a VTE risk assessment tool for them. No one has ever provided any guidance to them about how they manage VTE risk. And some of them have pulled out the National Risk Assessment Tool for Obstetrics, crossed out a few things and added a few other things. We have to help this group. This is definitely an area of unmet need. So that brings me on to talking about thromboprophylaxis. And this is the last Cochrane review, 2021, pitiful number of studies, none of them large enough to show us that thromboprophylaxis in pregnancy is effective or what dose to do. We're all using low molecular weight heparins because they're safe, they don't cross the placenta, and we have predictable actions, so we don't need to monitor. But what do we do differently from really the rest of the world? Well, we weight adjust doses, and we have this table in the RCOG guidance saying use these different doses for different sizes. What's the evidence for this? Outside of pregnancy, where are the randomized trials? Nothing. In pregnancy, nothing. But we are a little bit spooked, I think, by our levels of obesity. Just to show again, in England, BMI greater than 30, well, it's more than 26 now. In France, it's 17%. And then we have to come back to why are there no RCTs of thromboprophylaxis in pregnancy? Well, it's a hard science. We've got a rate of 1 in 1,000 bouts of VTE, so we'd have to do massive trials if we wanted to get anything meaningful out of them. And the background environment, you have to say, is misogynistic. There's very poor funding streams. Even now, more than 50% of all funding goes to male diseases. And there's a huge amount of paternalism, for want of a better word, about women who are pregnant. We've got to protect them. We mustn't put them in trials. So what happens? All our guidelines extrapolate data from the non-pregnant population. And we give vast amounts of low molecular weight heparin in pregnancy. I'm a bit of a feminist, and I've had a rant in this editorial about how bad things are, and we have to change. I am also a rheumatologist, and with rheumatologists, we've been looking at how difficult it is to get a trial of a chemotherapeutic agent in rheumatology patients, because at every step of the way, someone is saying, oh, I don't think you should do that to pregnant women. But how are we ever going to get all of the funding and the trials sorted out so that it's the regulators, they're paternalistic, the ethics boards, the sponsor, the funders, the trial team have to battle on, and then the patients themselves. We get very poor recruitment rates in pregnancy, probably because we don't sit down for long enough to talk to the women about what that trial means for them and their baby. I want to dwell on obesity and weight-adjusted thromboprophylaxis and just show you what's happening in the other areas outside of pregnancy. So this is a fabulous study from Prandoni, who's a world expert in thrombosis, a systematic review looking at the benefit of weight-adjusted thromboprophylaxis in medical patients who are obese versus standard dose. What do we find? it's not associated with a lower risk of VTE, although we don't have increased bleeding rates. And then we have this huge trial looking at, it's a systematic review looking at trauma patients. Now, trauma is the place to do trials for VTE because there's such high rates. And so they've looked at weight-adjusted thromboprophylaxis versus standard, and they say there's no evidence to justify adjusting low molecular weight heparin doses in agreement with the American College of Chest Physicians, who have always said use standard dose thromboprophylaxis. But I just want this paper to be out there, because I think many of you know about it. It's called the High-Low Study. Saskia Middledore, who led on it, sweat blood to get this out, and she managed to do a trial in women who've had a previous VTE and are pregnant into taking intermediate dose, which is really what we do, versus fixed dose. And the fixed doses she used are, here we go. We've got enoxaparin. The standard dose for enoxaparin, if you were less than 100 kilograms, more than 100 kilograms, she's using 6,000 units. And look, she's managed to recruit over 1,000 women in a multi-centered study in pregnancy. That is an amazing feat. Look at all the countries involved. When we look at the average BMI, we've got average BMI of about 25. Our average BMI in the UK is hitting 28, so not quite the same population. And when we look at those who are over 100 kilograms, she's got about 10% in each group. I think in the UK we'd have more than 10%. But never mind, let's look at what she found. So we have got a graph at the top here looking at rates of VTE. We're going through pregnancy, we're delivering, this is postpartum. The blue is the standard, sorry, I can't see myself. Anyway, the intermediate dose is the one that is red, and the blue is fixed dose. And we can see that antenatally, we've got no difference between the two. It's just postpartum, it might be better to give a dose of intermediate, give a higher dose. And then at the bottom, we've got bleeding risk. So we have got similar rates with the two, but postpartum, we've got a higher bleeding rate with the intermediate dose. So this data suggests to me we don't need to give weight-adjusted thromboprophylaxis, certainly in the first trimester, where we have only got a doubled risk of VTE. And it would make life so much more sensible. If we've got GPs prescribing low molecular weight heparin, it's too fiddly to go through all of these tables. They just want to know, what dose do I prescribe? And it will be 40 milligrams of enoxaparin, less than 100, and 60 over 100. What's coming through? We've got Mark London in Geneva. He's going to be looking at fixed dose low molecular weight heparin postpartum. I think one of the issues about these studies is he's got only 1 in 6 of the women who are eligible actually wanting to take part. This problem. And Leslie Skeeth in Canada, she's going to be looking at low-dose aspirin versus placebo in women postpartum, but not going to help us with our question about low molecular weight heparin. What have we done? So there was a group of us that looked at where would be the best place to do a study to prove that thromboprophylaxis works in pregnancy, and we focused on obese women who have got other risk factors postpartum. We did this for NIHR, and then Embrace came along, and I know there's going to be a call, but it won't necessarily be about this. So what am I suggesting to you? I'm suggesting we could abandon a weight-adjusted doses, and certainly in the first trimester, before they see obstetric care, we could suggest to the GPs, let's just use very simple fixed doses according to weight. The only quibble is we do have women who weigh 150 kilograms. Should we make another tier for them? We haven't got any evidence, or should we just give them that bigger dose? Okay, I'm going to end on some more positive notes. Anti-embolic stockings in pregnancy, no evidence at all. We have some studies in stroke that showed no benefit at all. 2,000 stroke patients randomized to stocking versus no stocking. No benefit, but quite a lot of harm from skin breaks. This is the GAP study. This looked at moderate risk surgical patients. They all got low molecular weight heparin, and then stocking versus no stocking underneath. Came out during COVID, got totally lost, but showed no benefit from stockings. But this is what's coming through. This is so exciting. So this is our PET study. This is looking at anti-embolic stockings in low-risk surgical patients. They don't need anything else, and they're randomized to stocking versus no stocking. And then we find out if they have VTE in the next 3 months. We aimed to recruit 22,000 patients. A couple of months ago, we got to 11,000, and the statistician said, stop, you've got your answer. So we're just pulling the trial together, and we will hopefully be publishing in a couple of months, hopefully in a nice big high-impact journal, because we think stockings don't work. If they don't work in surgical patients, if they don't work in stroke patients, please don't use them in pregnancy. There's no rationale. Lastly, management of PA in pregnancy. This is your guideline. For goodness sake, how out of date is this? We've got a new classification of PE. We all say low, intermediate, high risk. We use the PESI score. It's absolutely magical what you can do with an intermediate risk PE if you work with a PERT team, pulmonary embolism lysis team. We use catheter-directed endovascular thrombolysis and thrombectomy, and we have centres all over the country who specialise in PE. Surely they should be linked in to your maternity networks. There's only a handful of cases that have had catheter-directed thrombolysis. We should be doing trials in them. But there's no modern guidance that looks at pregnancy-associated PE. All of the guidance, and there's a lot now on intermediate risk, does not include pregnancy. But we do have the matron study coming through. So this, led by HemeStar and your obstetric registrars, is doing an audit of intermediate and high-risk PE retrospectively. It's closed. We've got 80 patients recruited and analysis to start. This will tell us how variable the care of PE is in the UK and give us a basis to try and start improving the situation. So we've got a lot of work to do. This whole crazy lack of research in pregnancy, especially in VTE, has led us to this lack of evidence and this awful state we're in now. And we have to enter a new age where there's funding and willingness to do trials, and we will get some good trials. And there are a lot of unmet needs, especially in the first trimester, and these need addressing urgently. I'd just like to thank Francesca Reeder, who is looking at risk factors in pregnancy with me. We're hoping she's going to do an MD and be co-supervised by Kate Duggan, who's leading on the work to improve VTE care in the NHS England group. Thank you.
Thank you very much, Beverley. That was extremely interesting and a pleasure to listen to, as usual. So we have a few questions coming through from the platform. So one of the questions was, well, excellent presentation. One of the main issues we have in our unit, this is a question from Brenda, is compliance with injectable medication, especially in multiple doses, if they needed to adjust for the BMI. So is there any research coming through with regards to DOAC use, especially in the postpartum period?
So we know we can't use DOACs in pregnancy. They're small molecules, they apparently cross the placenta. Postpartum, there is a place for a trial of DOACs, and the other place where there's real scope to do a trial, which is where I'd hope to start, is post-abortion care if you're high risk. So yes, we could start looking at those areas.
Great, thank you. A question from Bassem El-Sagir. So when looking at weight to determine dosage of Clexane, do we ever take into account gestational weight gain or simply the pre-pregnancy weight only?
So that's a question for Kathy Nelson-Piercy. She always says no, doesn't she? And we should base our dosing on the pre or the first weight that we get.
So we've got time for a couple of more questions, if there's any from the audience.
Sorry, and actually that question is saying, oh, we should be using weight-adjusted dosing, and I would argue we don't need to be using weight-adjusted dosing.
Okay.
Make life a lot simpler and cheaper.
I've got one question. So one thing which intrigues me so much is the fact that we have quite extensive VTE prevention guidelines, which most other countries, I suspect, do not have, but we have one of the highest VTE rates. So why are we getting it so wrong? Is it literally just a BMI issue, or is there other things going on, you think?
I think obesity is a major factor, and we have a lot of, our population isn't as well as mainland Europe. And the other thing is, are we giving the low molecular weight heparin to the right women? So if you see, if you admit people with intermediate risk PE, many of them don't have risk factors, about half of them don't have any conventional risk factors. We are missing a major risk factor. For me, I think it's probably flow through the iliac veins. But we need to do some more research there.